Hello and welcome. My name is Adrian Banning. I work in Oxford and I'm the President of the British Cardiac Intervention Society. We're in London at the ACI conference. We've had a very busy day, but I'm pleased to say 3 colleagues and friends have taken some time to talk to me today about treatment of heavily calcified disease and how our treatment of these very challenging patients has changed really over the last few years. I'm joined by Peter O'Kane from Bournemouth, Andreas Baumbach from Barts and Colm Hanratty from Belfast. So I'm going to start with you, Peter, if I may. Calcific disease, clearly it's been around a long time. Why is it more of an issue this year than it was perhaps a few years ago?
Well, I think we're treating much older patients than we were maybe a decade ago. I think we're challenging not only ourselves with some of the complexity of the coronary disease we're treating, but also the patients, the way they present to us. They're healthier and they're coming with very advanced coronary artery disease, which is very calcified. We know from our own experience, certainly in our centre in Bournemouth, 20% of the patients we treat are over 80, and that's so calcification is an everyday experience. And from the literature, we know it may affect up to a third of all cases we treat. So it's definitely there, and we're recognising it more and more. I think we're also doing more coronary imaging, so we're seeing a lot more, and therefore we're anticipating some of the problems, and we're also developing our skills with some of the tools to help decalcify these vessels.
What are the hazards of treating calcified disease?
Well, I think it starts really just even with wiring. If you're not careful, you can dissect vessels quite easily with a wire if it's calcified. You might overdilate a lesion and perforate a vessel. You may have an undilatable lesion that may end up, if you put a stent in, you might get an underexpanded stent, which could be a real hazard for the future. And I think all the literature tells us that any kind of calcification is associated with increased target vessel failure, leading to stent thrombosis and MI. So it's a problem. It's a problem across the board, and we really have to understand how to best to treat it and prepare vessels.
So I'm going to pick up on that point about poorly dilated stents. Just talk me through the hazard of the poorly dilated stent, particularly in this patient group.
Well, I think if you are unlucky enough to have an underexpanded stent at the acute PCI, then the risk to the patient is that they're much more likely to get acute stent thrombosis, and even if they don't get a stent thrombosis, they're much more likely to have stent failure in the first 6 months, requiring repeat revascularization. So it's imperative to avoid putting in a stent if it's likely to be underexpanded. And if you have got an underexpanded stent, then Andreas and Colm will talk through some of the techniques to try and treat that.
Certainly one of the things that we've seen in older patients is you never know when something else is going to happen to them. You know, they come in for an elective PCI, next thing they've got cancer and things like that, and ultimately there may have to be interruption of scheduled dual antiplatelet therapy. And that combination of surgical intervention, interrupted dual antiplatelet therapy and poorly deployed stents, unfortunately, is a very kind of flammable mix, isn't it?
Perfect storm.
So, Andreas, we've had balloons around for a long time. There are these what we might call conventional balloon strategies. Do you want to just talk me through what we had sort of 5 years ago, really?
What we would do
Yeah.
normally, so if you talk about calcified lesions, I think we have to differentiate whether we see just calcium on the angiogram, on the IVUS, or whether we're talking the napkin ring,
Right.
Calcified lesion that is hard to be crossed even with a balloon and impossible to dilate. There are two things.
Right.
It's impossible to dilate and impossible to completely dilate. What we always had is balloons, and we had high pressure balloons, so we proudly went up to 20 atmospheres, used that, cranked it up to 25, way outside the IFU, of course, and sometimes indeed brute force works.
Yep.
A bit more sophisticated, we think, are the balloons that have blades or a wire.
Yep.
Outside. The cutting balloon was the oldest model and is still around, with 3 blades attached to the short blades attached to the balloon, and the scoring balloons do the similar thing with wires wrapped around. Right. The principal idea is that if you only manage to cut into the calcium, the force that the balloon exerts is higher. You only need to crack a little bit of the ring to be able to expand better. So the cutting balloon set out with 3 cuts to make the lesion and the artery more dilatable. The problems with these balloons, of course, is they are a bit bulkier.
Yep.
And if you have a true napkin ring where just the wire goes through, even these balloons can't act. We do have, recent addition to the armamentarium, the ONP balloons, the very high
OPN,
pressure
yeah.
OPN balloons. I always say it wrong. The very high pressure
So
balloons.
it's 40
that
atmospheres
are
potentially.
40. You can do 55.
Right.
They just don't burst. They take away more or less the risk of balloon rupture, and they apply this pressure in
In a more focused.
in a more focused way where it needs to apply without the rest of the balloon overinflating.
And you're a TAVI operator as well. Have you seen much more calcific disease coming for intervention since we've started to do TAVI? Has that changed some of the patients that you treated?
Yes, only today we had a problem case discussed in the MDT. The target is the aortic valve.
Yep.
The problem is a dominant, heavily calcified right coronary artery. The patient can't have surgery, so we're faced with a really difficult angioplasty prior to the TAVI. These are things we now take on because we have the tools.
Right.
We probably wouldn't have done that when we both started angioplasty.
So technically difficult lesions in very technically challenging patients. I mean, the combination, again, is very flammable. But I think what we're kind of talking about actually remains the importance of lesion preparation, and that ultimately there's no point trying to put a stent in until you've actually released that lesion.
I heard in the past the strategy that actually you don't need a cutting balloon because the stent is practically the same.
Yeah.
You put the stent in, the stent struts will cut into the... But you open yourself up to the risk of underdeployment, and that is pretty much the worst that can happen. Having an underdeployed stent in a relevant artery because of heavy calcification, you don't want to be in that situation.
I think the only man or lady that says that is someone that hasn't done enough. So Colm, rotational atherectomy, certainly for the lesion that Andreas was talking about, where really we can't get anything across, rotational atherectomy is really the standard therapy there. You've got a lot of experience with rotational atherectomy. Talk me through your views about where rotational atherectomy stands in 2019.
I think it's been the mainstay of calcium modification for many years now. It's very old technology, while there have been some upgrades in the equipment which we'll come on to. But in essence, it's an oval-shaped device with diamonds on the front half that differentially modifies calcium. So it will shatter the calciums. You're not trying to debulk the calcific lesion. You're trying to disrupt the calcium to allow then good stent expansion. It's old technology, as we mentioned. It's an over-the-wire equipment, so that means you have to get a rotafloppy wire, which is an over-the-wire 300 centimetre wire into the distal vessel, so there's challenges associated with that. Because of the size, it's an 010 wire. It's a steel wire, so it's different to the wires we're used to working with day to day. So instead of wiring it directly, you're much more likely to have to wire with a standard wire and do wire exchange. So those are skills that an operator has to have. And then you bring down the rotablation, which, as I mentioned, is an over-wire system, and you try and modify the calcium. All those steps are different from what we do normally. So the great appeal of the cutting balloon, the scoring balloon, it's using your standard workhorse wire, your standard balloon technology, the monorail systems we're familiar with, and that's very familiar to a lot of users. To switch to use an over-the-wire system does require additional skill sets. If you're not doing it routinely, it becomes foreign to people. You're less likely to use it. And if, for example, you looked at the uptake of these technologies, in some centres it's 7-8% of overall cases. Your centre, Peter's centre, Andreas' centre, some other centres it's less than 1%. And that simply reflects that it is viewed as a complex procedure.
Traditionally, rotablation would have been 8 French femoral sheath, it would have been a temporary pacing wire. How do you do it in Belfast?
Yeah, and of course that was back when you were trying to, in essence, debulk the lesion. Nowadays, most cases we saw today from the updated figures from our BCIS returns, 90% of our cases are done radially, and that's for a reason to reduce the complications for patients. You can do up to a 1.75 millimetre burn, a 6 French guiding catheter very comfortably. Most patients will take a 7 French guiding catheter, especially if you used a slender sheath. So we will do the majority of our cases via the radial approach. The temporary wire is an invasive procedure. A lot of complications, for example, TAVI relate to the use of temporary wires. So
right.
we don't use temporary wires anymore.
Yeah.
We try to keep the runs to a minimum, so we would do short packing runs, less than 5 to 10 seconds. I think the chances of the no reflow is when you do big long runs, you build up a lot of debris which then goes downstream. That's when you get the no reflow.
So in Belfast, would the strategy be, well look, let's just try this with a balloon, or if you think you're going to use rotablation, would you just use rotablation up front?
I think we're so comfortable within the centre that we've got enough expertise that if you're thinking, I wonder, should I? You probably need to. And what you often find is that taking the rotablation up front will actually shorten your procedure.
Right.
Where you get into difficulty is when you try to modify, try to bully a lesion. Often the lesion doesn't give within the calcium, it gives at the interface between the calcium and other disease, which is then a tear, which leads to perforation and complications. So there's nothing like a shortcut to extend your procedure.
Peter, you've got a lot of experience with rotablation.
Yeah.
You're going to try to do this with a tiny burr and then scale up, or do you just go straight for the burr that you think is probably going to do the job?
I think as Colm says, I think we've moved away. We did quite a lot of early two burr strategies, starting small, going bigger. But in essence, we're just trying to get through the lesion to modify it enough to get the rest of the equipment through and get adequate balloon dilatation. So my strategy would generally be probably use a 1.5 burr for most of the cases. And then I would take a 1-to-1 balloon, non-compliant balloon, and go up and make, if that adequately expands, I've done the job. I'll often use imaging as well to just clarify that I've done enough. What's really good with the imaging is to look for calcium fractures. So if you've modified it with calcium fracture and it's pretty obvious that you can see them, then I think you've probably done enough for most of the cases.
You have laser as well in Bournemouth. How do you decide laser or rotablation?
So, laser has some advantages over rotablation, the main one being that it works on a standard 0.14 wire, so you don't have to put a dedicated wire down. But it doesn't really work for very heavy calcifications. So the heavy calcified lesions, without doubt, rotablation. If it's moderately calcified and it's focal, then laser's quite efficient and quick, because you just have to apply it to the lesion and often it will work. Again, just to modify it enough to get the balloon down and finish the case. But I think, all these devices, we used to use laser to help us get the rotor wire down, but now with the microcatheters being so good,
right,
that's less of an indication.
So it's the CTO techniques kind of helping your more difficult angioplasty. So, and there's been sort of a technological step forward after about 20 odd years with rotablation, Colm. You got some experience with the new console?
Yeah, well, as you know, the old technology, you had to be in control of both hands and both feet at one time, and there's very few procedures that involves you to use all 4 of your limbs, assuming you have 4 limbs.
And breathe at the same time.
And breathe, so for the male, that's a very complex procedure. The new device has been modified so that you do not need the pedal anymore, you can control it all from the advancer. So it certainly has become much easier to use. Unfortunately, you still need the same wire, but there is a new wire coming along, a Rota Elite wire, which will have the same sort of 1-to-1 torque response that we have with our traditional or standard wires. So that will allow for you to wire it up front with the Rota wire and then move straight to use of rotablation. So the advances will certainly help in terms of the efficiency of the procedure and also the effectiveness of the procedures.
Andreas, one of the new things, it's really, actually, it was highlighted in this meeting last year. It was only 12 months ago. Great live case from the Glasgow group. An stent that they tried to expand, and it talks to Peter's point, they tried a 40 atmosphere balloon, were unable to expand this stent in a critical position in the proximal right coronary of a very heavily calcified vessel. And they used this lithotripsy balloon to expand the stent, and we saw it with our own eyes. While the lithotripsy pulses were being delivered, the stent being expanded. What do you think of this new technology, and how does it move us forward?
It's fantastic new technology, and it's fantastic to have that in the armamentarium. It's been a long time coming. Just talk through the principle. This lithotripsy we know from kidney stones, right? So it's a method to apply ultrasound remotely, but in a focused beam to disintegrate kidney stones, make them smaller so that they can go away. This principle is translated into a balloon inside the coronary artery, so you have to get a balloon in, and then aims at the calcium around the balloon, the calcium in the vessel wall. You apply shocks, the ultrasound in a sequence, and what it's supposed to do is it's supposed to disintegrate the calcium. It breaks the calcium bonds. It doesn't make it disappear.
So this is calcium deeper in the vessel?
the calcium doesn't go away, it doesn't move, is my understanding. It's just the bonds of the calcium. So rather than having one big chunk of calcium, it breaks apart. So you have
So
little chunks of
disrupting those
calcium,
plates, yeah.
which then will enable expansion.
So we blow up the balloon, we administer these pulsed, focused sound beams. What does the patient feel during that?
The patient doesn't feel anything, really. This is ultrasound. If you block the artery with a balloon, you may get the usual chest pain, but it's short sequences, really. The pressure used is minimal. It's a small inflation just to bring the balloon in contact with the vessel wall, and then you apply the shock waves, and that's the name.
So essentially it's a simple balloon technology with this ultrasound within it?
With an integrated shock device.
So
yeah.
does it take a long time to do? Is it quick? Is it easy?
It is very easy. I mean, you bring a balloon into the lesion and you push the button.
Wow.
It is that easy. We have limited experience with it, but so far 100% success rate. It's a bit like, you know, following rotablation, when a previously undilatable lesion all of a sudden, you know, the balloon goes up at 4 atmospheres, and that doesn't seem to be a problem whatsoever. I think a word of caution, we're still learning.
Right.
There's no data on the device. There's no data on the success rates. There's no data on the long-term results. All of that is coming. It's extremely promising, and I'm very, very happy that we have now access to this technology. But if you, for example, look at the first case that was shown last year, this is not in the instruction for
Right.
use.
Yep.
And there are some things you just have to think about. For example, the ultrasound may actually interfere with the polymer drug coating of a drug-eluting stent.
If you're using it intra-stent.
If you're using it intra-stent.
Yeah.
So the jury is not out, but we have to think this new principle through, and we have to also rely to being informed by the company what is good and what is not.
And I was reading and listening actually to Carlo Di Mario, who's been using it in iliac arteries.
Now that is clever.
Yeah.
Yes. So for the TAVI operators, this is a tool where, you know, what keeps us from putting the sheath up the iliac artery is very frequently just a little area or a short area in the iliac artery that has circumferential calcification.
Bottom of the aorta, just at the top
exactly,
of the iliac.
and you're not, you know, it's not flexible enough. You just can't expand it. It hurts the patient. You cannot advance the sheath, and there are now numerous cases, and I've seen some in live cases and in reports where the same simple principle applies. You have the wire in, you put the larger shockwave balloon in, you apply the shockwave, and the ring of calcium doesn't go away but disrupts, and you are able to advance a sheath.
So going back to the coronaries, Colm, have you used the lithotripsy balloon?
Yes, I have. It's certainly a disruptive technology and very exciting technology. I think it will be complementary to rotablation rather than replacing it. Where I see a role for it is actually in the larger vessels, where to modify it with rotablation you would need to take it to your 2.5 millimeter burr. So for that deep wall calcium, it's ideal. I think scenarios where you've got a bifurcation and to use rotablation you would have to take one of the wires out of either the main branch or the daughter branch. And that's an uncomfortable situation for us, especially if that's a left main stem. So it will allow you to modify calcium having a wire in both branches. I think the underexpanded stent, and while that's not in the IFU, the only option for an underexpanded stent that has been deployed is rotablation, and that's really not much fun.
Right.
So while I accept that it will probably affect the polymer and probably strip off the polymer, certainly on the luminal aspect of the stent, I don't see that as a big issue in the long term. If it allows you to get a stent well expanded, you can put another stent within a stent. We do that all the time. So I see it as being a fantastic adjunct. It appears that you need a lot of circumferential calcium. So if it's like eccentric calcium and you need an arc of up to 270 degrees really to get effective effect from the shock wave. So what we do in Belfast is we mandate the use of imaging up front. And if you do not have 270-degree calcification, you don't use shockwave.
Yes, it's an interesting, I mean, it's ideal in some respects. The more severe the calcification, the more likely this technology is going to help you. And have you imaged after the stent deployment? What are your thoughts about the quality of the results that you've had subsequent to shockwave?
Yeah, it is certainly very, very good. We've actually used it in the CTO space in the subadventitial, where you've got a heavily calcified vessel, but the equipment is sitting outside the vessel, and it's absolutely no effect in that scenario. And it's basically the sound waves are heading out to the path of least resistance, which is the adventitia. Where you've got circumferential calcium and it modifies it very well. I think we haven't done anything to the coronary that's been as disruptive, in that, you know, the energy applied. So whether there's a consequent down the road in terms of restenosis from the injury, I think we have to wait and see. But there's certainly some early anecdotes of aggressive restenosis. So I think, for example, there's 80 pulses with each balloon,
yep.
8 by 10. I don't think we should feel obliged to use all 80.
Right.
And I think the least number of shocks that you apply to the vessel to get the job done is what you should do.
So that's right. I mean, it was going to be interesting as to how this technology is incorporated into our practice, although actually, to a certain extent, you know, it's an example where practice has almost leapfrogged the clinical trials. So Disrupt 2, which is I think it's something like a 12-centre registry, European registry, is not yet complete, but many labs are using this technology to help treat calcified lesions.
And just we're reporting that this is mechanical energy which is then dissipated. So we've noticed that you will get ventricular capture or shock topics, and especially if the patient's heart rate is around 60 beats per minute. So what you will get is a capture from the shock topic. We don't think that is of significance other than it will cause hemodynamic compromise in some patients. So for the period of that shock topic, you can get a drop in blood pressure. There are also some reports of it interfering with the pacemaker interpretation. So you may have to reprogram your pacemaker to a backup mode. It's interesting that it is not gated. So if you go for extrinsic lithotripsy and get your kidney stones, that is gated, ironically, but the coronary device is not. So that is something that we need to understand, but there's not a noise that is going to be associated with a bad outcome.
Certainly our experience has been that it is very simple technology to use. The results have been very exciting, I would say. You know, we have seen really spectacular results, final stent results, which you wouldn't have got, I think, with standard technology. And I think it is going to change, I think, the way we approach some of these lesions going forward. And change our algorithm, perhaps, actually. You know, we've got rotablation, which ultimately starts in the lumen, and this therapy, which essentially is treating more the media and adventitial calcium. And obviously, I think the other thing to say about shockwave is that when we end up trying to treat a calcific ring, it's not infrequent we end up dissecting the vessel. And you've got that awful position where the napkin ring is still tight, but you've dissected perhaps before and after, which is clearly extremely dangerous scenario. So I think the predictability of response of this new shockwave technology is going to be something which I think is going to be valuable.
Well, the area that appeals to me most, though it has not been studied yet, is actually in the post-stent deployment. And I would make an argument for routine use of this to optimize your stent after it's put in. Now, that needs to be understood in terms of research with regards to the effect of the polymer. There's talk about pitting off the stent, but I think contemporary stents, and certainly if you've got an abluminal polymer, then you're not going to be effective in the luminal aspect. And I think if you then put in stents in a long, heavily calcified vessel using guide catheter extension, and then use the shockwave balloon to optimize your stent.
Well, certainly, I think there's no doubt that we can't be complacent about our results. I think that's one of what you're hinting at there, and something that your group are very good at, is not just getting the stents in and saying, right, take your gloves off, we're done. You know, you've talked a little bit about imaging. The need for us to get, we're never going to get perfect results, but the need for us to get really good results is very, very evident in this group of patients in particular. So Peter, for you, Is this shockwave going to change, you think, how you approach calcium?
Well, I think as the guys have described, I think it's having it within the toolbox. I think it offers us the opportunity. I think for me, imaging up front is key, because then you can identify which best tool to choose. Because some cases are going to be better done with rotablation, some better with shockwave, some better perhaps with laser. But I think we probably will use it for more cases than we anticipate at the moment, because it's going to be appealing because it's quick, it's simple. But I think if we use it in the wrong cases, then we're going to get not such good results. Going back to the stent under expansion, we have used laser in under expanded stents quite successfully, and I think that's going to be an increasing role for shockwave as well. Clearly it's going to work. I totally agree with Colm, the effect on the polymer is going to be negligible, I think, and we can end up putting another stent in if necessary. But we have to also, as Colm suggests, understand how many pulses to give so we don't over-injure the vessel to maximise the result, and that's going to be the sort of area of studies and trials to understand how to do it best.
So that's the final word from you, Andreas. In your practice, in your elderly patients with aortic stenosis, shockwave first, rotablation first, balloon first, how do you see it kind of integrating into this very kind of demanding patient group?
I think, as we've just heard, I think we will develop these algorithms. We will find where it sits. The napkin ring stenosis, the rotablator or the laser, I think, is the way forward, because if you can't get the balloon in, you can't use the shockwave. The undilatable lesion that can take a shockwave balloon, and you can document 270 plus circumferential calcium, I think that will be the domain of the shockwave balloon in the time to come. And certainly once you have deployed a stent and the normal methods of post-dilatation don't work, you wouldn't care about the polymer in this situation. I wouldn't make it a strategy firsthand, but if you have the situation of an underdeployed stent due to calcium, then that's where it sits. I think this is disruptive technology, and I think that will find a way in routine practice in these patients.
I mean, we haven't talked about cost, but actually the cost of a stent thrombosis is really absolutely terrible, both financially and for the patient. So, I don't think there's really any question that if we can do our job better, it has to be the way forward.
Yeah, I think an underexpanded stent is really our worst nightmare, isn't it? It's the one thing that we really hate to see.
In a high-risk patient.
In a high-risk patient.
Well, with that, I'd like to thank Peter, Andreas, Colm for your participation. I hope you found this useful webcast. Thank you for your attention.